Hi everyone, my name is Julia Chase. I'm the Senior Patient Engagement and Recruitment Specialist at Praxis, as well as the Advocacy Lead for our DEE programs. I'm joined with Kelly.
Hi, everyone. I'm Kelly Del Real. I'm the Director of Patient Strategy at Praxis. Most importantly, I have a son, Connor, with a DEE. And when he was diagnosed about 10 years ago with an SCN2A mutation, I wanted to start working in industry to work on treatments for his disease and other patients that present similar in symptom to him. And then I'm not the only person that works at Praxis that has a child with a DEE. And so what this means is that the patient lived experience is being brought into all of our program team meetings in that sense of urgency. We know every day matters for children like ours. And then Praxis does not operate like a traditional biotech company. We're constantly innovating to have families make it easier for them to join clinical trials. And one way we're currently doing that in the Emerald trial is we've figured out how to bring the clinical trial to the patient's home. So we're offering a fully decentralized option. So it removes burden complete or travel burden completely for families. And then Praxis is an epilepsy company. So all of these different programs are unique epilepsy programs at Praxis, except one of these is for a movement disorder. But we have two programs. So one platform is a small molecule platform, and this is where relutrigine sits. This is the drug we're going to be discussing today. And then we also have an antisense oligonucleotide platform, or ASO platform, and these are gene-specific ASO treatments. We have one currently in clinical development for SCN2A gain-of-function patients, and the others are in preclinical development. And then I know for me, as a parent with a child with a DEE, after trialing the first 3 or 4 anti-seizure medications, without any of these medications really decreasing his seizure frequency, I lost a lot of hope that the next medication would do anything different. But I want to make it really clear that relutrigine has a completely different mechanism of action than anything else that's currently available today. So relutrigine is in the class of sodium channel blockers, but it is a sodium channel modulator. And what that means is relutrigine is selective for the hyperactive neuron. So traditional sodium channel blockers are blocking all sodium channels, very different than relutrigine targeted to the hyperactive neuron. So when neurons are functioning normally, relutrigine leaves those neurons untouched. With a lot of anti-seizure medications, we have to slowly titrate up over a series of weeks or even months to get to a therapeutic dose to then assess if the anti-seizure medication will be efficacious. With relutrigine, there's no titration required whatsoever. So essentially, the dose that you start at is the dose that you stay at, and caregivers will be able to tell very early on if there's efficacy with relutrigine. It has a very long half-life, about 5 days long, so it only has to be administered once per day. And the half-life is so long that if a caregiver accidentally misses giving medication, one day it will not even affect the levels. For this trial's purpose, it's a liquid formulation, so it can be administered either orally or by G or J tube, however the patient takes the medication. And there's no added sugars, so it's ketogenic diet friendly. I want to touch on the different phases of drug development relutrigine has been trialed in. We started in a phase 1 study, and this is a trial for healthy volunteers to study the safety profile of relutrigine. Based on the data that came out of this phase 1 study, we were able to move to a phase 2 study in a patient population. We started with a cohort of SCN2A and SCN patients called the EMBOLD study. When we did an interim analysis in this trial, the data was so efficacious that we added a second larger patient cohort. And then we also, in parallel, started a phase 3 registrational trial for Emerald, so in broader DEEs. This is the last trial for relutrigine, and there's a couple years in between the end of a phase 3 registrational trial to base case scenario and the drug is approved. So this would be the last opportunity for anyone interested to trial relutrigine until there's another mechanism available to access it. Then I want to touch on the data that came out of our EMBOLD study. So SCN2A and SCN8A patients could remain on their standard of care anti-seizure medication regimen. So the best possible anti-seizure medications that they were on, and then adding relutrigine on top of that. And when we did an interim analysis at the end of the double blind or the 4-month mark, we saw a 46% reduction in seizures. When we did the second interim analysis, so all patients in the open label extension or 11 months on relutrigine, we saw a 90% seizure reduction. And this is really the opposite of what we tend to see, where when we start a new anti-seizure medication, there can be a honeymoon period where we see efficacy for the first few months, and then for whatever reason, the drug is just not working as well as it was in the beginning. With relutrigine, we're seeing sustained seizure control. There were no severe adverse events due to drug, and no patients required a dose reduction of relutrigine due to any side effect. And then when we did the interim analysis recently, it was just in December, with a much larger cohort of SCN2A and 8A patients. So all patients at the 4-month mark in the double blind, we saw very similar results. So we saw a 53% reduction in seizures, and then patients weren't yet in the open label extension, so that data is coming. But the fact that at the 4-month mark, it was slightly improved than what we saw in cohort 1, we fully expect the open label extension data to be similar. We saw also, in addition to the 53% reduction in seizures, a 66% increase in seizure-free days. And then in addition to the primary endpoint of reduction in seizures, we also utilized several scales in EMBOLD, which we're using in EMERALD as well. One of those is called the CGI, and we pulled out specific domains that we know are problematic in this patient population. So we looked at disruptive behavior, and this is whatever that disruptive behavior is unique to the child on day 1 of the trial, so on the day of screening. We looked at alertness or awareness, communication, and then seizure severity and intensity. So how often is rescue medication being used? Are the seizures clustering? The scale is administered to the clinician and to the caregiver on the day of screening, and then again at the end of the 4-month mark or the end of the double blind. And we saw improvements in all domains. Specifically, I want to call out a 78% increase in alertness or awareness, according to both the clinician or the caregiver. And this can be the opposite sometimes of what we've seen when sodium channel blockers or anti-seizure medications are added. We can see potentially improved seizure control, but maybe sedation or being overtired or sleepy. We saw the opposite here, where we're getting seizure control, but improved awareness and alertness as well. And then we did receive breakthrough therapy designation for SCN2A and SCN8A patients based on the data that came out of the EMBOLD study. And what this means is the FDA gives this designation when a new therapy has a better efficacy profile and a better safety profile than anything else that's currently available. And then the drug development timeline is sped up, so this medication can get to more patients as quickly as possible. We, depending on the data that comes out of the EMERALD study, we will then look to also obtain this designation for DEE patients. And then relutrigine has much broader applicability than just sodium channelopathies like SCN2A and SCN8A. So regardless of the root cause of seizures, whether it's a syndrome diagnosis or a genetic mutation, there is going to be hyperactivation in the sodium channels. And this is precisely where relutrigine steps in. So any neuron that's firing too fast or too often, relutrigine brings that neuron back to a normal state, and the expectation is then a seizure will not occur. Relutrigine was trialed in a pretty large library of different animal models. So we have our SCN2A and SCN8A mouse model data. And then I also want to specifically call out SCN1A. Sodium channel blockers are typically contraindicated where they can worsen the seizure frequency or severity. With relutrigine, we saw the opposite, where there was seizure reduction. So it further illustrates the unique mechanism of action of relutrigine being a selective molecule of the hyperactive neuron. And then we also trialed relutrigine in 5 additional epilepsy models, and we saw efficacy across the board. And then for the Emerald trial design, we have options for families. So if a family wants to either travel to a study site or they live local to one of our study sites and be seen in person, we do have that option for families. The majority of families that enrolled into Embold and also Emerald chose the remote from home option or the decentralized trial option. So I'm going to walk through the study design with this option in mind. So on the day of screening, a physician and a nurse that are licensed in the patient's home state travel to the family's home, and the PI or principal investigator joins via telehealth. All of the assessments and scales, all of the labs, everything is done from the family's home. And then for the next 28 days, the caregiver is just filling out a daily electronic seizure diary. If at the end of those 28 days, the patient has had a minimum of 4 seizures and all of the labs are within normal range, then the patient is randomized into the trial. Emerald is randomized 1-to-1, which means for the next 16 weeks or 4 months, 50% of patients will be on placebo and 50% of patients will be on relutrigine. And there is a study visit once per month. Again, all of those visits occurring in the family's home. At the end of the 16 weeks, families can roll into what's called the open label extension, which just means there's no more placebo group. Every patient is on relutrigine. And then anyone seeing efficacy on relutrigine can continue on into an expanded access program built into the protocol for an additional 3 years. So families don't have to worry at the end of the trial. If there is benefit, they will have to stop relutrigine. We have a program in place so that there's no need to stop relutrigine if there's benefit or efficacy. And then really to go into a little bit more detail about the decentralized model. So the PI or the principal investigator at the site is still the physician that has oversight over the patient during the trial while on relutrigine. And this PI has oversight over the physician and the nurse going to the family's home. So we equate it to the nurse and the physician in the home are really the hands of the PI joining via telehealth. And then with regard to the patient's primary neurologist, they can be as involved in the study as the caregiver wants them to be. So we've gotten a lot of requests that a lot of the labs drawn in the study, could those be shared with the primary neurologist? At the request of the caregiver, yes, they can. Everything except the PK studies of relutrigine. And then the primary neurologist can confer often with the PI at the study site, as often, again, as the caregiver wants. With regard to who can participate in Emerald, so anyone with a diagnosis of a DEE, and then it's a pediatric through adult trial, so has to be a minimum of 2 years old through 65 at the time of screening. Seizure onset just has to have happened by 12 years of age. A minimum of 4 motor seizures in that screening period. And then patients can remain on their anti-seizure medication regimen. There's no cap on the number of ASMs a patient can be taking, but only 2 of those medications can be true sodium channel blockers. And then we make it really simple for any families interested in learning more or taking the next step and wanting to screen at a trial site. We have resilientstudies.com. That's our trial specific website for all of our DEE studies. There's a page on Emerald. Some of the information we covered today is on that page, but you would schedule a call with a nurse navigator at a time and a day that's convenient for you. And then you can either ask the nurse navigator specific questions. If the child or adult is eligible to be transferred to a study site based on some of the information you provide, like age, current medication, seizure frequency, whether the patient has a genetic mutation or a syndrome diagnosis. So, based on the answers that come out of that pre screening call, if eligible, the nurse will transfer all of your information to the study site, and the study site will be contacting you within 24 to 48 hours. That would be your opportunity if you want the PI to have a conversation with your child's primary neurologist, and then you would be reviewing the informed consent. And the next phase of the process can go as quickly as families want it to. So if you know after having a conversation with the PI and reviewing the informed consent that you want to move forward and screen for the study, that can happen very quickly. If you need more time to think it over, or again, have a lot more questions or want to check in with your child's primary neurologist, that's fine too. This would still be the next step for families to take to get more information or to schedule a screening. And then that was it for slides.
Thank you so much, Kelly, for that presentation. Again, for anyone who joined late, this is Dr. Lauren Schmidt, the Chief Science Officer.
All right. Well, if any other questions come up, feel free to reach out by email, and then you can contact Julia and I.
That sounds
Absolutely.
great. I really appreciate it, Julia and Kelly, for being here. This has been great information, very straightforward. I hope we're able to bring some families to you if they are interested and eligible. And like I said, we will make sure this recording gets out to everyone who registered as well as the rest of the community, and we will summarize this Q&A and send it out.
Okay, that sounds
Great.
great. Thanks so much for everyone's time.
Thank you, everyone. Have a good
Have a
rest of
great
your
night,
night.
everyone. Bye.
Bye.